Um, People, I guess, are fairly willing to say this is the worst headache ever. Maybe because they feel the necessity to justify their visit to emergency department. You got to say something. You can't say it's an ordinary old headache, no big deal. So they have to defend it, and by saying that, they don't realize the consequences of what they're saying. And so I think that this does put this into perspective. That even when they say that, a third of them said it. Only 3% of them had subarachnoids, but you got to go down that path if they're starting using that as phraseology there. You sure it's the worst heck you've ever had? You want to take it back now? I'll give you another chance. In this study, 47% of the patients had CAT scans, only 32% of them had lumbar punctures. The literature will show you that there's a big disconnect between doing CAT scans and doing lumbar punctures. So you ask the question, what is the standard of care? If the standard of care is not every soul who gets a CT gets a lumbar puncture, then it brings up the issue of, is standard care the standard of care? Standard of care is not to do them all. But if you get into a legal situation here with Joe coming to defend you, he's going to say, you should have done the lumbar puncture. So it's a disconnect, and this happens not infrequently in medicine. I'll show you paper after paper after paper. When you miss a subarachnoid hemorrhage, some of these papers are going to, have to be used to help you out. There's one paper here that is incredibly strong in trying to help you out in terms of saying, well, not all the time do they do it. What's the risk of having a having a subarachnoid if your CT is negative? If you told the patient and they said, no, I don't think I want to do it based on that, if you document that, maybe you'll be okay. This paper number 4 talks about thunderclaps, maximum intensity in 10 minutes. 137 cases of thunderclaps. It has to be a chart review. You could never prospectively. It's going to take forever to find 137 cases prospectively. They followed them for 1 year. All described an alarming experience with severe pain and dramatic symptoms. Of the 137, 17% had subarachnoid hemorrhages, 1 in 6. What was the rest? God only knows. God only knows. If you follow them for 1 year and nothing happened, does that mean that they all had benign causes? Probably, maybe not all. The median age for the subarachnoids is 58. That's the same age for dissection of the aorta. Surprisingly young. CT was normal in 22% of subarachnoid hemorrhage patients. CT was normal in 22%. 22%. That seems like a really high number, 22%. Were they doing anything that was a precipitant of this headache? Were they doing, anything that would have precipitated a thunderclap headache? And 2/3 of them were at rest when it came on, just out of the blue, which certainly would be a very frightening kind of thing. And 1/3 of them were doing something that involved some kind of vigorous activity. Nausea. 90% of the patients with subarachnoids had nausea, 60% of those who did not. Well, that's not going to help you any. And then in this paper, they list a bunch of symptoms. Well, most of these symptoms here are certainly not the symptoms of a warning leak headache. They're talking about neck stiffness, impaired consciousness. That is a bona fide, you got a subarachnoid hemorrhage kind of thing. We're concerned about the subtle cases. We're not concerned about the obvious cases. Interestingly enough, prior migraine headache was noted in 22% of the patients who had a subarachnoid hemorrhage. 22%, and 28% in those who didn't have it. So this thing of migraine should not make you feel comfortable when they come in and say, well, it may be another migraine. But if they say, no, this is not like my normal migraines, boy, that ought to send the red lights and sirens going off in your head. So our concern is really, what's the true incidence of warning leaks? What's the true incidence of warning leaks? If you could tell people that, they might be able to say, okay, well, now that I know that, I understand why I should or should not get this lumbar puncture. Number 5 is a review of 9 studies, and it concluded that between 10 and 43% is the sentinel headache rate. The sentinel headache rate, but they said, how do you define that? That's a headache defined as recurring within 3 months of your diagnosis of a subarachnoid hemorrhage. So I think if you ask people who have had subarachnoid hemorrhages, in the last 3 months, have you had an occasionally nasty headache? What are they going to say? They're more likely to say, yeah, I probably did. We're not concerned about that one. We're concerned about the one today in you. You came to the emergency department. You're not normally here for the emergency department to have a headache. Are you having one today? So that's, and we're going to give you some numbers on that because it's important to kind of know what the risks are here. Number 6 says the yield of CT in acute, sudden onset non-traumatic headaches, or syncope. I don't know why they throw that in there. In a retrospective study of 891 cases at a single university, was 1.1% subarachnoids. Boy, pretty low yield. At a university, maybe they have a very low threshold for doing CTs. 3.6% had a potentially serious problem, so they throw in the brain tumors in there as well. Of the 35% of the patients having a CT, 3% had a subarachnoid hemorrhage. 3 out of 32% a brain tumor. Now look at this. Only 22% of the patients with a negative CT had a lumbar puncture at this university hospital. A university hospital certainly ought to know better. Only 22% of people having a CT that was negative had a lumbar puncture. Unbelievable, unbelievable. And CT was positive in 8 of the 10 subarachnoids, so it missed 2. We're really interested in this distinction between warning leaks, though. Number 7 says, how good are doctors at picking up subarachnoids? And they picked up 95% of them, but it's very misleading, because you see the subarachnoid that comes in, it's vomiting, the corticate kind of thing, and you know, that's kind of obvious. So yeah, you could be real good at those. We don't care about that. We care about the subtle headaches, the warning leaks. In this study, when they asked doctors, what do you think about the likelihood of subarachnoid in this person? They had 50 patients. All of them were picked up on CT or LP. 3 of these cases were thought by treating physicians to have a 2% chance or less of a subarachnoid. So they said, oh God, doctors are really good at picking this up. Well, I think that you have to be more careful and say, we're really only interested in how good you are at the subtle warning leak headaches. So doing the math, they said physician sensitivity for the clinical diagnosis was really good, big deal. The characteristics of delayed subarachnoid hemorrhage diagnosis is 8, 9, and 10. Patients are a little younger. 8, 9. Well, it's not. You don't need to be a rocket scientist to do this. They had atypical headaches. They had headaches that didn't make people think that they were subarachnoids, obviously. So they were a little younger. Clearly, they were less symptomatic. Don't even think of having any kind of focal neurologic deficits, decrease in level of consciousness, none of that. Less likely to present to a teaching hospital. Well, I wouldn't go to the university hospital that only did 22% of the patients with, getting a lumbar puncture, that's for sure, I wouldn't go there. But they said that, I don't know. The initial misdiagnosis rate, you need to have your lawyer see this one. The initial misdiagnosis rate in these papers is between 5 and 15%. So it's kind of like appendicitis. You're supposedly be allowed to miss. So the question is did you do a thorough exam? Were you negligent in your exam and would some other doctor have picked this up and you didn't? But there is clearly a miss rate, which is not inconsequential, between 5 and 15%. Another group of people who had the diagnosis delayed are they people who had a CT without a lumbar puncture. Okay, we'll give them that one. And failing to order CT was also associated. You didn't even think that this headache was bad enough to even warrant a CT, and it turned out to be a subarachnoid. But the question is, okay, so I missed the subarachnoid. You come back 2 days later. Now it's more obvious. Is the outcome worse? Now, if the outcome's not worse, no harm, no foul, what are they going to sue you over? This is probably the only paper in the literature that will say this, but Joe, number 9, there is no significant difference between misdiagnosed and correctly diagnosed patients in mortality, 18% during hospitalization, and 24% at 12 months. So I said, tell your lawyer. You're shaking your head, Neil. You don't agree with that, Well, I got to have some paper to defend myself. Come on, you're going to have the papers that say it. I'm going to have one at least that said, hey, no difference here, no harm, no foul. Next question. These really good CAT scanners, if we have a 5th generation CAT scanner, can we skip that lumbar puncture thing? And the answer to that is we just don't know. There's not been any studies done with all fifth-generation CAT scanners in enough patients with warning leaks to say definitively the answer is yes or no. So the answer to that is until we have new information, we must stick with what we do know. And what we do know is you can't rely on a CAT scan to exclude subarachnoid hemorrhage. So I think the more interesting question then is, well, what percentage of patients who have warning leak headaches in the setting of a subarachnoid really do have negative CAT scans? Well, number 11 is a 2000 paper. 2000, they're obviously not using state-of-the-art CAT scan machines, at least to our standard now. It says that the risk of a subarachnoid hemorrhage with a negative CT could be 7% or higher. Okay, so that was one number. I'm going to give you 4 papers that give you what they approximate to be numbers. There's 7%. So, all right, well, we'll just put that aside. 7% of people could have a negative CAT scan and a positive LP. Jerry Hoffman in number 12 says, he concludes we should not pretend to be able to give a patient any precise probabilities and that the best current information strongly suggests that a CT is simply inadequate to rule out a small subarachnoid hemorrhage warning leak. Well, Jerry, if you look at the word precise, we can't give you a precise estimate. We know it's not 75%. We know it's not 50%. We know it's not 25%. So the fact of the matter is we can give you an estimate. And the range is surprisingly tight, as 4 papers will show you. Before we get into that a little bit more, what's this LP first approach, where you don't do a CAT scan, you just go right to the LP? They say, well, if your CAT scan machine is broken and it's a hassle, just do a lumbar puncture. They say, fine, do the lumbar puncture. It requires that you have no change in mental status, no neck stiffness, no focal findings or signs of increased intracranial pressure when the CT is not readily available, and do a lumbar puncture. And they said the sensitivity of a lumbar puncture at 12 hours after symptom onset approaches 100%, which is better than the sensitivity of a CAT scan machine. And so some people would say that's the thing to do right off the get-go, but and Jerry Hoffman will argue that's a reasonable thing to do. I don't think any doctor in their right mind is going to routinely do a lumbar puncture first in these cases. They're all going to get a CAT scan. They're going to get a CAT scan sometime in their treatment. They take minutes to do. Who would ever do a lumbar puncture first, unless there was extenuating circumstance? The CAT scans and machines down. The closest hospital is far away. Fine, okay, just do it. And the fact of the matter is that we do lumbar punctures in a lot of people who have elevated intracranial pressure. Meningitis, intracranial pressure is up. I guess this is about this differential and the opportunity to have your cerebellum go down into your foramen magnum kind of thing. But, the pseudotumor cerebri, what do they call that? It's got a better name now. What is the new name for pseudotumor cerebri? Idiopathic intracranial hypertension. All of those people, they got high intracranial pressures. So you could do that. Yeah, this is a reasonable thing to do. Everybody's concerned about coning. It's not going to happen. What's the latest with regard to CSF analysis? All of these papers focus on xanthochromia. And they ask the question, do you have to do spectrophotometry to determine if this fluid is yellow or not? And number 14, let me see if I don't want to miss one here. 13 says, xanthochromia at 12 hours is a better indication of a subarachnoid hemorrhage than red cells, but visual inspection can miss up to 50% versus spectrophotometry. The papers here basically are either for it or against it. So this paper says you can miss half the cases without doing spectrophotometry. Any of you use spectrophotometry to, well, it's unanimous. The standard of care is to use visualization of this stuff, not use it. Now, if these papers were correct, it would be another situation where what doctors do and what doctors should do is different. But you'll find in these cases, the papers are really very polar. You're either for it or against it. So this says you can miss up to 50%. But number 14 is a British recommendations based on 700 cases that they reviewed. And they said spectrophotometry for xanthochromia was advised on the last bottle from the CSF that you got. CSF bilirubin is usually accompanied by oxyhemoglobin. I have no idea what that is, but in any case, if both are absent, the diagnosis of subarachnoid is not supported. There's a 2004 paper there, which is number 15. This tells us a couple of things. 463 patients suspected of subarachnoid with a negative CT and no neuro findings who had LPs more than 12 hours, but less than 2 weeks after the symptom onset. More than 12 hours, but less than 2 weeks, so all of them had negative. This is a big study, 463 patients. 9 had an aneurysm and 10 had other non-aneurysmal subarachnoid hemorrhages. So 19 out of 463 had subarachnoid hemorrhages. That's 4%. Now, the one paper said could be as high as 7% or maybe a little higher. Here's this next one paper. This says 4% of people, 4% of 463. So the number is pretty small. None of the 297 patients without xanthochromia per spectrophotometry had an aneurysm diagnosed. This is really good. If it's negative on spectrophotometry for looking yellow, you don't have a subarachnoid hemorrhage. So that paper told us two things. 4% is another number we can use in terms of how many people who have a negative CT will have a positive LP, 4%. And they basically said spectrophotometry excluded every case that did not have a subarachnoid.
But this is 12 hours after.
Well, I was going to point that out. Now, in some of our ERs, they may be waiting 12 hours to get their LP if they came in and they had it in the parking lot. So that is an issue. It is an issue. The longer you wait, supposedly, the more likely this fluid is to be yellow. And, but I'll show you a paper that talks about traumatic taps also having xanthochromia.
No, CT is more useful when in the first 12 hours, isn't it?
CT is good. They all had CTs. And then there was this gap of getting their lumbar puncture of up to 12 hours. Did I get that right there? Who had LPs more than 12 hours, but less than 2 weeks. So they let them sit around a while before they did their lumbar punctures. Is that a good thing to do or a bad thing to do? Well, they're into xanthochromia. They said xanthochromia is the cat's meow here in terms of making this diagnosis. You have to let those red cells lyse and before they generate this stuff. And so what do you think, Neil?
Early repeat hemorrhage is the worry. So you're going to sit around and wait and see if they maybe can hemorrhage.
Well, we wouldn't do that in clinical practice. So the question is does that dilute down the answer that this paper gives, that xanthochromia, if you wait 12 hours, will make the diagnosis, will exclude the lack of it will exclude the diagnosis? And more importantly, does it change the number that says 4% of the patients with a negative CT had a subarachnoid? I don't think it changes that at all. So, and 16 is similar. They compared visual inspection, and this is one of these anti-spectrophotometry. It compared visual inspection of the CSF with spectrophotometry in 220 patients having a lumbar puncture for suspected subarachnoid hemorrhages. 2 patients had the diagnosis of subarachnoid, 2 out of 220. And I'm assuming, but I looked at the abstract and we were neglectful in not putting in this key piece of information. I'm assuming all 220 of these had a lumbar puncture, a CT that was negative, and that's why they got the lumbar puncture. This would suggest, if that's true, that 1% of the people who have a negative CT will have a subarachnoid. So the numbers now are 1, 4, and 7. 1, 4, and 7. But this paper said spectrophotometry was not a good thing to do. It said spectrophotometry had a high false positive rate, and routinely use would have resulted in many more additional workups. Just the opposite of what the other papers say. And 17 says xanthochromia can occur as a result of strongly positive taps. So we don't use xanthochromia. There is a literature that says we don't use spectrophotometry as reflected by your hands. And the literature on it is quite mixed. But the standard of care appears to be not to use it. And then, coming towards the end here, is a negative CT and a negative lumbar puncture sufficient to rule out a subarachnoid hemorrhage? Depends on who it is, I think. We had a resident, a USC emergency medicine resident, and he had a thunderclap headache, and he had a negative CT and a negative lumbar puncture, and nobody felt comfortable in just saying, okay, go home, see you done. And so he had one of these MRAs, and that was so cool to watch it, look at this guy's blood vessels in his head. This is your head, this is your middle cerebral artery kind of thing. It was very cool. This paper, 18, says, yeah, you're done. Now this was published in the Annals of Emergency Medicine, which surprises me. You would think that a paper answering this really, really important question would be in JAMA, Lancet, New England Journal, something. What the heck is it doing in the Annals of Emergency Medicine? 592 ED patients evaluated for subarachnoid hemorrhages. They were fully awake and oriented. That, you have to have that. They had a history of headache reaching maximal intensity within 1 hour. They presented to the ED within 14 days of the onset of that nasty headache, and there was no history of trauma in the previous 7 days. Lumbar puncture was considered positive if there was xanthochromia on visual inspection or if there was a certain number of red cells. And subarachnoid hemorrhage was diagnosed in 61 of these 592 patients. So 61 of 592 is about 10%. So now the numbers are 1%, 4%, 7%, and 10% of people who have a negative CT will have a positive subarachnoid hemorrhage based on their lumbar puncture. It ranges between 1 and 10. And I think, honestly, based on these 4 papers, you could tell a person, well, what's my chance of having a hemorrhage in my head, doctor, if the CT is negative? And you could say, well, it could be as bad as maybe 10% of the patients could have a hemorrhage, which allows them to put this in perspective. Now, I think that I've seen some doctors try to talk people out of lumbar punctures, and you've seen your colleagues do that as well. Well, we have to put a big needle in your back, and it's going to hurt like hell kind of thing, and we're going to suck out your brain juice, kind of, oh God, oh God, oh God. See that wall suction? We connect that to the thing and suck it out of there kind of thing, and they frighten them. This number should put the number in perspective for you. 4 papers. You're not going to probably find any better information. Well, this says, do we have to do anything further? So they found 61 hemorrhages. Of the rest of the patients who had negative workups, they followed about 90% of them were followed for at least 6 months, and none of them had anything further. Well, first of all, is following somebody for 6 months good enough to say, well, your aneurysm that you had has not manifested itself within 6 months, you don't have a serious problem or not? I don't know where they picked 6 months. Another study picked 1 year. So that may be something that would make you feel a little bit uncomfortable about this study. 19 says identification of a cerebral aneurysm in patients may be an incidental finding in patients with thunderclap headaches, and now you're going to connect the dots and come up with the wrong conclusion that aneurysm caused that problem. And now we have to go digging down into your brain to clip this thing, which was not the problem in the first place. And they say the size of the study that needs to be done to answer this question is going to result in not knowing the answer to this for a long time. They say, while additional study may be warranted in some cases, routine angiography is unnecessary and potentially harmful in neurologically intact patients with thunderclap headaches and a normal CT and a lumbar puncture. So that's kind of on the don't bother, you're done side. The number 20 says, not so fast. They say there are 12 diagnoses that can cause a thunderclap headache, and many are identifiable on additional study. So their list is there: subarachnoid hemorrhage, arterial dissection, vasospasm, vasculitis, aneurysms, arterial occlusions, dural sinus or cortical vein thrombosis, pituitary apoplexy, whatever that is, and posterior circulation vasogenic edema with hypertensive crisis. They therefore conclude the history, both personal and family history, physical exam, and other ancillary tests might help to establish the pretest probability of a specific disorder, and the authors believes MRA or MRV or digital subtraction angiography, depending on the circumstances, should be considered for some patients with thunderclap headaches but a negative CT and lumbar puncture. That's what they said. They said 21 says it's an easy test to do, but it identifies aneurysms that may have nothing to do with your problem. So 21 says, we're not ready to make the recommendation to keep on going down the path in these cases. They said a change in standard practice should not occur until a large study is done. They have, however, they say, they had a study, 5 patients with a confirmed subarachnoid. CT was positive in 4, LP was positive in, LP was negative in 2. So they basically said, you know, you might find an occasional case. So what is your experience in this regard? Some of you obviously have done other things other than CT and LP in patients that you were very concerned about. So you have to tell us now your stories about what happened on your CTAs of these cases. Anybody?
In our group, we had one person that had kind of sudden onset posterior headache in their neck a little bit.
Well, that's the next abstract.
And they were thinking, oh, maybe vertebral dissection, but also subarachnoid in the diagnosis. And then they just sent them right for the MRI.
And did it show something?
Yeah, they found an aneurysm, and everybody started arguing whether it's an aneurysm or not.
So anybody else basically was involved in a case where they went the next steps and found something? You have to go, you should only respond if you found something. Because the whole question here is it worth going to do a CTA in these cases where you're quite suspicious? Neil, what do you think?
Gotta base it on an individual thing. I'll talk about the limitations of all those studies in just a minute.
Limitations? Limitations?
They all start with, they say, let's look at every diagnosis we've had that had a subarachnoid hemorrhage diagnosis. And then they look through the CAT scans and their LPs and all that kind of stuff. They don't look at everybody that came in with a bad headache and what happened to them. So it automatically eliminates people who never got a CT for it. So that's why those numbers are all skewed by that. Every study starts that way, and so you miss them. So if there's a migraine, we sent them home, and they went back to their other state and died of subarachnoid hemorrhage. You don't find it.
I think that's probably true. It's going to change the numbers a little bit. Lastly, 23 talks about vertebral basilar artery dissections. So this is what you went to the chiropractor for, your neck was bothering you, and they turned your head around 4 times on its axis in the process of giving you your adjustment. And now you come in with a vertebral basilar artery problem, dissection. And they point out in 23 that there are 2 presentations of these cases, and they reviewed 30 patients who had it. They were between the ages of 50 and 80, and half of them had a hemorrhage, subarachnoid hemorrhage, and half of them had a stroke, an ischemic stroke. So they fall on either side. 18 of the 30 presented with a headache. Even those with the ischemic strokes had headaches as the only initial symptom. 11 of the 16 with subarachnoids and 7 of the 14 with ischemic strokes. Of those patients with headaches, the diagnosis was often delayed. The mean delay was 2.8 days in subarachnoid hemorrhages, 1.3 days in the infarctions. Headache location was, when they noted a chart in the chart, it was occipital in 8 of 10 cases, nuchal in 2 of 10. So of the 10 cases where they said where the headache was, it was always in the back of the head or in the neck. Sudden onset was 6 out of 8 because it's, you're implying some kind of mechanical thing. All of a sudden, bang, this is happening. 3 patients presented with warning headaches. All of them were discharged home and returned within 24 hours with major symptoms. So they're talking about being aware of sudden onset occipital or neck headaches that are unusual, never had it before, kind of nasty. CT, MRA, those kinds of things are something that, so you don't miss this diagnosis, which in this case, this study, they were routinely missed or delayed in terms of their diagnosis. Okay, any questions, comments, disagreements?